Well, welcome everyone to our diversity webinar for applicants this year. My name is Amanda Gosman. I'm from UC San Diego, and I am going to kick us off with a few updates about what is going on from the ACAPS perspective in terms of trying to kind of increase the commitment to diversity and inclusion amongst plastic surgery training programs. So just hold on a second. I'm going to share my screen. Yep, awesome. Okay. So, I'll just go ahead and start from the beginning since it's a little bit out of order. But as many of you may know, we've kind of really launched a social media initiative through ACAPS to reach out to applicants this year. And one of the great advantages of that is really trying to kind of push it forward to address the diversity issues. So this week we had a really great coffee talk by three of the residents that talked about their perspective of looking at residency programs and launched our diversity challenge as well. And this webinar is kind of kicking off or kind of concluding our week, but certainly obviously diversity and inclusion doesn't get solved in a week. And this is really hoping to be an impetus to get the programs really on board, as well as the applicants to be able to evaluate programs from their perspective and be discerning about what resources and what work needs to be done going forward. So if any of you aren't following us on social media, we definitely encourage you to do that. This was a diversity challenge. We had over 50 participants in that challenge in the last several days. So that's been really wonderful to have programs be able to share with the public kind of what their commitment is and what their perspective is. So certainly for underrepresented minorities that are looking at residency programs, you know, I think a lot of programs have a long way to go in terms of developing the outreach and the infrastructure to support improved diversity, but everybody's, I think, really interested in moving that forward. Just to put this out there for any of you that may be a little bit uncomfortable putting questions in the chat, we do really hope that this is going to be an interactive webinar and people will be able to engage in a dialogue with our panelists. If you don't feel comfortable doing that, we do have a survey that's been open for the past week where you can submit questions anonymously. And we do have a list of those questions that have been accumulated over this past week, and we have someone monitoring that. And I'd like to just give a shout out to Greta Davis, who is also an applicant this year, who's really the artist and a lot of the muscle behind this entire initiative. She's done a fantastic job. The other initiative that we started as a part of this program was to really help provide liaisons for each residency program, both a resident and a faculty who could be contacted to discuss diversity issues about the program environment, about the work environment, so that you know, anyone who has conversations that they'd rather have individually or offline. This list is now posted on the ACAPS website, so you just go to the homepage and click on the diversity link on the first page, then it will take you to that. We're also listed under diversity, equity, and inclusion. We are hoping that this will kind of take the leap that ASPS had taken to really become a formal committee. It's a task force at this point in time that just started in this past year. And one of our co-moderators, Julie Park, who's on here, is one of the co-chairs along with Ash Patel. And on to our webinar. So here's our lineup for this evening. Our first speaker, as I mentioned, is Wendy Chen, who's currently doing her hand microsurgery fellowship at UCLA and finished her plastic surgery at Pittsburgh, and has really done an incredible job raising awareness about many important issues in plastic surgery through social media and through her research. And she'll be giving us an introduction and a little background about the diversity, inclusion, and equity issues in plastic surgery and kind of where we stand, current state. Paris Butler, I'd really, for most of us in plastic surgery, needs very little introduction, but is an assistant professor at University of Pennsylvania And we were just chatting before we went live about how he published really a landmark article over 10 years ago about representation in academic plastic surgery and how there hasn't been a ton of progress since that time. And we're hoping that's really going to change. Paris has been a leader on diversity and equity issues. He's a member of the ASPS New Diversity, Inclusion and Equity Task Committee, and we really look forward to hearing his story. Haripriya Ayyala is our resident representative, and she's at Rutgers, and she has also been really a great collaborator in pulling a lot of this together, and we're really glad to have her here as a part of this lineup today. And last but not least is Michael Galvez, who is a pediatric hand surgeon in Central Valley in California at Valley Children's Hospital, who has also been incredibly active in building a lot of grassroots organization around identifying diversity inclusion issues on social media, and has a very unique story of his own. So basically what we're going to do is kick it off is we're going to have Paris kind of talk a little bit about his journey into plastic surgery. We'll go from Paris to Hari to Michael, and then we will open it up for questions. And we're going to have at first, before all of that, a little background by Wendy. So Wendy, are you in a place where you can share your screen?
Yeah, so
awesome.
Share screen. Here we go, this guy. So I'm having the Zoom on, okay, good. The computer is not on a great connection, but the phone is on a good connection. So hi, everybody. Welcome to this diversity webinar. So when you think about diversity, I think we think of a lot of things. You know, we think of gender, race, LGBTQIA status, what kind of socioeconomic background you're coming from, if you're first generation low income, whether you're rural and serving that population, or if you don't have a plastic surgery program at your institution, what kind of religion and nationality you come from. And these are just like maybe some of the bigger things that people think of, but certainly not at all all inclusive. And so when you think about diversity in plastic surgery, you know, where have we been and what are we interested in? So, you know, we talked about Dr. Butler's paper, which really inspired me when I first read it. And then we've been looking at representation at meetings and in leadership, and the status of attitudes on LGBT colleagues, family planning, and also race. And if you want to know what we have been doing in terms of scholarly interest in plastic surgery, is this green line. And really kind of around 2013, I'd say, is when the pace started picking up a little bit, okay? And some positive things I think to look to in plastic surgery, because some people had asked about that, is that in terms of female trainees, we're at about 40%, which is pretty high in terms of surgical subspecialties. And that really started coming up in the last 10 years. Plastic surgery recently passed one of the most, or one of the best family leave policies in all surgical specialties, and that's 3 months total. And that was passed earlier this spring. ASPS will be led by its first openly gay president in 2021, and he was also the only openly gay past chairman of the American Board of Plastic Surgery. ASPS just created its first diversity task force this year, and interest and number of fellowships in gender affirming surgery is on the rise. And this is not plastic surgery specifically, but you know, first generation low income students are finally getting some attention and organization, and they just had their first conference this year in the spring during COVID virtually. And so I think if you don't already understand the vocabulary of diversity, equity, inclusion, or maybe you intuitively understand it, but I think it helps to articulate it. So diversity is the presence of difference within a given setting. Representation is the acknowledgement of that presence and being able to see your diversity. Inclusion is when people with different identities feel or are valued, and maybe their different identities are leveraged and even welcome. Equity is an approach that ensures everybody has access to the same opportunities regardless of your starting point, because some of us may start much closer to a goal than other people, and to make sure that everybody has access to those opportunities is equity and not just equality. And somebody said it to me, Dr. Woodbury from West Virginia, best, I think: it's no fun being invited to the party and never being asked to dance or being ignored. Okay, so how do we get there? So I think some things to prepare yourself for are recognizing microaggressions when they happen to you, knowing what constitutes workplace bullying. Do you recognize your own socialization and whether or not it's working against you and that you have to overcome that? One example would be imposter syndrome. That's the most obvious example. And then, you know, you should know that women and underrepresented minorities of any kind, whether it's race or other things, you are at risk for burnout and mental health symptoms that may or may not last a long time. But when residency is difficult, especially in a long residency, you want to just take note of that and take note of your wellness and make sure that you are not going down a little rabbit hole by yourself. And so as soon as you arrive at residency, these are the things that we're going to talk about. So I'm not going to go into them in depth now, but kind of know what offices are there to help you, and what kind of services they offer or don't offer, and kind of transition your coping mechanisms so that you can be successful in residency, know policies for family leave and requirements for graduation, kind of things like that, you know. And again, I think one of my mentors, Kia Washington, said this to me once, and I thought it really helped change my perspective, which is that you deserve not just to survive, but to thrive, you know. And it's time's up for everybody, no matter what your background is, to thrive in residency, not just the people that are a little bit more privileged or fit in better to the existing culture. And so, you know, also one of the questions was, are we doing better, or are people supportive? And I think social media is a place where you can see where the supporters can be visible, you know. And just in this last few days, you can see that a lot of people really did come out to support. Oh, I think it's lagging a little bit. Oh, it's lagging. I have this picture up of like all the social media posts that people had posted in support of this diversity PRS week. And so welcome everybody to the first ACAPS webinar for diversity and inclusion in plastic surgery residencies. Sorry about my internet connection.
Oh, thanks so much, Wendy. Appreciate it. So if you want to unshare your screen, then we can, oh, there it is. Yeah, it really had
There it is, yeah.
more successful.
All right, stop share. Sorry.
All right, so I guess we'll transition now to Paris, if you don't mind taking it away for you know, about 10 minutes and kind of talk about your journey in plastic surgery.
Sure, thank you very much for the invitation. I'm hoping that this is one of many as it pertains to these kinds of conversations and webinars. So as Dr. Gosman very kindly introduced, I'm a faculty member at the University of Pennsylvania. I'm not going to give you my entire history, but I'll kind of walk you through a little bit as to how I became so involved in diversity, equity, and inclusion work. It wasn't something that I immediately gravitated to, with all honesty. I remember having conversations with my mother growing up, in college in particular, saying, you know, why do I really have to be, if I'm the only Black guy in the class, like, why do I have to be the person that talks about Black guy issues? And I wrestled with that a lot when I got into medical school, and realized through additional conversations with, you know, trusted resources like my mother and father, that I'm in a privileged position to be a young man of color in my medical school class. And if the conversations aren't happening and it's bothering me that they're not happening, then it's incumbent upon me to make them happen. So that's how I came to the understanding that it wasn't necessarily my responsibility, but I kind of owned it and made it something that was part of me and part of my fabric as I, you know, kind of pushed towards becoming an academic surgeon. So in short, I'm from Virginia. My father was military, and we moved around a lot growing up. I went to a small liberal arts school in Southwest Virginia called Roanoke College. So for all the students that are listening, if you started at a small liberal arts school, you've got every opportunity in the world to rise the ranks, just despite the fact that you don't come from an institution that has tremendous pedigree. So keep that in mind. Played basketball in college, ended up going to the University of Virginia for medical school. We're all good Virginia boys, want to go to medical school. I decided I was going to be a surgeon, and at the time when I was coming through, there weren't many integrated programs for anything, particularly in the South. Orthopedic surgery hadn't broken off all that long ago. Urology was still, they spent 2 years of general surgery training. Plastic surgery, there literally were, I think, 1 or 2 integrated programs in the entire South, which is basically below the Mason-Dixon. So I knew I wanted to be a surgeon. I didn't know exactly what type. I thought about plastic surgery, but I also thought about cardiac surgery, vascular surgery. My mentors were hardcore cardiothoracic surgeons who said that integrated models of anything were ridiculous and that we had to train fully. So I matched, ended up staying right at home and matched in general surgery at the University of Virginia. About 2 years in, decided I was going to be a plastic surgeon. That is also when I started to have some interest in disparity work. Charlottesville, Virginia is a small place, storied tradition, uncomfortable tradition of late as it pertains to some of the things that's transpired there. But within the confines of the campus, it was actually a fairly progressive place. So decided I was going to be a plastic surgeon. In order to become a plastic surgeon in the independent model, you basically needed to do dedicated research. So I decided, although that UVA did great cardiac research, they didn't do great plastic surgery research. So applied for some funding, was blessed to get some funding that I could attach to any active R01 in the country. So I had an interest in keloid pathophysiology because it impacted my community, and being a black plastic surgeon, I figured I'd get the question a lot. So there were 3 active R01s in the country on keloids, one of which was out at Stanford University. So I cold emailed those 3 labs, and within a few hours, I didn't realize my worth. I was free labor. So Michael Longacre, who I didn't know at all, emailed me and said, let's do a phone interview. So I did a phone interview one night on call. He also played basketball in college, so that was a conversation piece. And he said, you sound like a good egg. So I ended up going out to Stanford. 2 years turned into 3, as Michael Galvez can speak to as well, because he spent time in that same basic science lab. It's a place that is high on productivity. So the 3rd year, for my personal being and maturation, I wanted to do a master's degree in public health. And it just so happened that UC Berkeley was offering a 1-year program that if you already had an MD or a PhD, you could complete your MPH in that 40 credit 1-year time frame. And they were also offering some scholarship money. So I convinced Dr. Longacre that if I remained as productive the 3rd year in the lab, could I also get my MPH? And he agreed to it. So did my master's degree in public health. I also obtained a special certificate in minority health because I was, once again, chasing the formal disparity education. So did that, went back to UVA, finished my general surgery training, matched at Penn for my plastic surgery, 2nd residency, not fellowship, because it just extended to 3 years as I'm coming out of the lab. And after matching, one of my mentors on the general surgery side recommended I consider applying for the White House Fellowship. Many people may know about it. I'm not going to belabor it, but it's a big opportunity that started in the 1950s. They wanted to bring DC outsiders into DC to learn about policy and to bring some bright minds and some fresh ideas. So long story short, I was a finalist for the White House Fellowship. Dr. Cerletti, now my boss, then my chair, was kind enough to allow me to defer for a year. So I spent a year in DC as a policy fellow working in the Department of Health and Human Services, helping to unroll the Affordable Care Act under the Obama administration to underprivileged communities. And I worked in the Office on Minority Health. So I did that for 11 months, getting really great experience in using this master's degree in public health that I had received at Berkeley. So then I went up to Penn. I did my 3 years of additional training. So now we're at 12 years post-grad. And my wife said I had to get a job. So I was asked to stay on at faculty at Penn. I've been on faculty for 5 years now. In that capacity, my research interest has really been around disparities in the plastic surgery realm. So I do a lot of breast reconstruction, both autologous and implant-based. So I've written a fair amount pertaining to disparities in breast reconstruction. There are disparities within breast cancer that we talk about frequently, particularly within the African American community, but it frequently historically had gone kind of undiscussed about the fact that African American women and Latino women receive breast reconstruction at about half the rate as the majority community. So I do a fair amount in that. I do some community engagement with that. Recently submitted an R01 pertaining to disparity work. I also care a lot about workforce. So if you look at kind of this paradigm as to how we're going to mitigate healthcare disparities in this country, one of those big bullets that I put up when I give my formal presentations is about increasing diversity within the healthcare workforce, and particularly the academic surgical workforce. So my colleagues on this panel were kind in saying it was a landmark paper. It was one of the first, I was one of the first people to really look at it through the lens of the AAMC faculty roster. It was before it was readily available online. I actually remember having to write them in a letter in order to get the data from the AAMC. It wasn't readily available. You had to get special permission. So that was published in 2008, 2009 timeframe, and we've continued to look at it since. Wendy's continued to look at it. We've been collaborating on such things, and it's kind of a shame that the numbers really have not changed at all. If anything, they've potentially worsened a little bit since 2009. So with that, I will end my introduction. I'm looking forward to fielding some of these great questions that you guys sent through. But once again, I appreciate the invitation, Dr. Gosman.
Thank you so much, Paris. It's an amazing career that you've had already. So early still. So thank you so much for sharing. Hari, you want to go next?
Can you guys hear me?
Yep.
Awesome. So hey everyone, thanks for joining us tonight, and thank you, Dr. Gosman, for the introduction. So I'm a PGY6, and I was in all of your shoes not very long ago. And my journey briefly is that I decided very early in life that I was either going to be a surgeon or an architect. And I'm terrible at math, but good at the Krebs cycle, so I ended up on the med school path. South Asians are not exactly portrayed as a minority in medicine, but they certainly are in the surgical disciplines. So my parents grew up in India, no indoor plumbing, no electricity, and so they moved to the US so my siblings and I could have better opportunities. And when I told them that I wanted to go into medicine, they were ecstatic. But when I told them that I wanted to be a surgeon, they were devastated. And they asked me, how do you plan on getting married? Do you not want to have children? And I told them that's a stereotype, and stereotypes are meant to be broken. So I decided to become a plastic surgeon after attending the micro meeting in my second year of medical school. I did not have a home program, and I really didn't have any mentors in sight. So I ended up reaching out to one of the female general surgeons, and I hoped for some advice. And she told me that I did not have the fire to be a surgeon, and that the men in plastic surgery would crush me. Words I did not expect to hear from a female surgeon. So I guess she didn't follow the women support women hashtag. So I ignored her, and I applied anyway. I went on my away rotations, and on them I noticed that the guys were rewarded for speaking up in the operating room, and the girls were whispered about as being too assertive by the scrub staff. And some of the male medical students were addressed as doctor, which they did not correct, and the women were addressed as sweetie. And we didn't speak up because we didn't want to seem overly assertive. So at the end of one of my rotations, I asked for feedback from one of the male attendings, and he said I did fine, but I was too respectful. I was like, what? And he said he let it go because he attributed it to my South Asian heritage. He said that he understands that women in my culture are generally quiet and obedient. And so I thanked him for his time, and I moved that program to the bottom of my rank list. Honestly, I was very fortunate to match into a residency program that is already extremely diverse. In my 6 years, we have maintained a 50% female complement. Our residents and their significant others are representing really every underrepresented minority community. Most of us are bilingual or trilingual, which is really a godsend for our patient population. And I'm really fortunate to now finally have found some mentors that don't see gender. They see competent surgeons. That doesn't mean that there aren't any barriers, because when I lead rounds in the morning with my male intern, patients still sometimes only look at and speak to him, but I think we're going the right direction because he tells them that I'm the boss doctor. He definitely follows the he for she hashtag. I do remember feeling like a minority on my OA rotations. I remember other people discussing their personal lives, and I felt like I had to hide mine because it wasn't mainstream. And I'm happy to have matched in a place that doesn't really care about skin color or race or religion or sexual orientation, and all of our differences are really accepted. So my advice is 6 years is a very long time to be someone you're not. So definitely choose a place where diversity is celebrated. And that's pretty much what I got for me.
Awesome. Thanks, Hari. Michael, you want to go?
Those are incredible stories. So I am a pediatric surgeon here in California, and I'm originally from the Bay Area. My parents are from Peru, from Lima, and came here before I was born. And I grew up essentially without health insurance, and I did terrible in high school. I had a 2.8 GPA and was just hanging out with the wrong crowds essentially. And I got my act together when I started at community college. And it really was, and my whole story is always, when I talk about just opportunity. And so I just got lucky that I started community college and I saw something that I really liked. And I got lucky and was working in a genomics sequencing lab. I really liked it. And so that motivated me to do well. And then I transferred to UC Berkeley, where it was incredibly hard. And then did 2 years of research at UCSF, and I bumped into a plastic surgeon, a resident from UCSF. His name's Amarjeet Dosanjh, who I just talked to on the phone. And he's been an incredible mentor for me. He's originally from Fresno, actually, and he took me under his wing when I was applying for medical school. And so I ended up getting to Stanford for med school, and when I started in med school, again, opportunity. I was like, why don't you check out the Gertner lab or the Longacre lab? And so right when I started medical school, I was doing microsurgery in a research lab. And so that motivated me to go to consider plastic surgery very early on. And really just the opportunity of being at Stanford and having great mentors who took me under their wing and just taught me about how to be a good plastic surgeon and be a good surgeon. And so I've always been about outreach and mentorship from middle school, high school students, and college students. And residency doesn't really allow that, right? You just have time to prepare for your cases and stay afloat. And so I knew I wanted to do hand surgery very early on. As a medical student at La Paz in Bolivia. And there were so many kids. There was like hundreds of kids that had been screened before we even got there. And they all had congenital hand differences, they had burn contractures, they had missed trauma. And I remember a girl who was 13 who traveled 5 hours, and she had a full-on thumb duplication. And she wanted her thumb reconstructed, you know, she was 13 years old. And so that was my motivation. Hand surgery, which I did at University of Washington, and then a pediatric surgery fellowship at Texas Scottish Rite. And so I heard about this job early on in the Central Valley. And there's just so much need. And I mean, I've had a 13-year-old boy with a full lung thumb duplication present in my clinic. And so that has been my drive, has been improving access to care and mentorship as well. And so the pipeline has been broken for a long time. And so there's many levels. This is a discussion that can be had multiple times and multiple discussions, but I'm Latino. I'm a majority of California. True, I mean, we're 40% of the state, yet there are only a handful of Latino plastic surgery residents. And actually, I can't identify a plastic surgery attending at any one of the California residency programs. And so it's really and the question I always ask is, why does that happen? It's just there's not enough medical students that are Latino. There's not enough that are considering specialties, and this is why I've been very vocal on social media. I remember going on Instagram and being like, "There's nobody Latino who's a surgeon on here. I should just start talking about how it's important, how outreach is important." And so that's why I've been very active on social media, talking about diversity and inclusion issues. And so it's something I'm just really grateful that ACAPS has taken this on, because as Dr. Capers from Ohio State says all the time, that diversity drives excellence. I really think that that there is, there's a reason why we have higher rates of death from the coronavirus in Latino and African American communities across the country. It's just our lack of representation, the lack of our workforce, like Dr. Butler was saying. And so I think this is an important issue. And as far as my story, it's just moving forward and taking students on. And I like that I can tell students that traditionally, and this is also something that isn't talked about, but Latino students in the state of California, many are directed towards primary care. And there's no reason for that. I think you can choose any subspecialty. So I talk about this all the time. And this isn't just a plastic surgery issue. This is every surgical subspecialty issue. And I think we need representation. So I'm very grateful for this opportunity to talk here today in the webinar.
Thank you so much, Michael. It's awesome. We're getting a little bit of feedback on your audio. I don't know if you have an option to maybe try calling in on your audio too, just for the discussion part. I think we caught this very interesting story. I think we're gonna open it up for discussion and questions. We do have a list of questions that had come in through the survey over the past week, but also encourage anyone to put questions that they may have in the chat. You know, I have a question just kind of pivoting off of what Michael just said about, you know, being directed to primary care. And I was wondering if the panelists can talk a little bit about that. I think, you know, we definitely see a trend toward directing underrepresented minorities toward primary care, and what are possible kind of interventions that could be done to kind of address some of that direction? You know, Paris, do you have any thoughts about that?
So I've been thinking about that a little bit. You know, thankfully, I don't have a whole lot of experience with that. I've read about it. I've actually cited it in manuscripts, but I haven't come across, and I've been fortunate to be at relatively progressive institutions at, you know, University of Virginia and out at Stanford and here at Penn, where students, I think, are mentored pretty early on, that once they get into medical school, the world is their oyster. So I don't, thankfully, I've not seen a tremendous amount of, you know, even the Black students being pushed into, or Latino students at any of the institutions I've been in, pushing them towards primary care. I would say that maybe they haven't been mentored appropriately to be successful in obtaining a match in one of the more competitive surgical subspecialties, as far as making sure that they hit the ground running academically, making sure that they get some exposure to research opportunities. So I probably have seen more of that than I've seen overt direction into a primary care. So I don't know if any of the other panelists want to speak to actually observing it, but I would say it's been less of that and more of a just not equipping these students from the gate to make sure that they have the opportunity to potentially seek out a career in a competitive specialty like plastic surgery.
So, Hari, I want to ask you a question that was posted earlier. It's directed, I'm going to combine two of them. As a minority medical student, what advice would you give a first-year medical student interested in applying into a surgical subspecialty in plastic surgery, and a fourth-year medical student?
So for the first years, I think that going back, it would have been great to find some people to talk to about this. And I think that when I was going through the journey, first of all, I really didn't know any plastic surgeons, much less any women or much less any women of color. And so I think it would have been great to be paired with someone who has gone through this and could point me in the right direction. Not just for minorities, but even just like, how do I get involved with research? What is plastic surgery? How do I get connected to the network? Mentorship is really, really critical for success. And that's why I think it's great that ACAPS is actually taking, you know, the measures to connect people, especially students without home programs, who I still consider in a minority field. And then fourth-year students, this time I think you're already applying. So it's a little bit harder, but the fact that you guys are all in this webinar is great. In terms of when you go on your interviews and how to assess programs for their motivations in diversity and inclusion, I think it's pretty apparent at least when you see programs, Instagrams, they're pretty vocal about being diverse if they are. And if you're looking at their websites and their Instagrams and you're in their interviews and you only see a very monochrome or very not diverse faculty or residency, that may not be the place that you really want to spend 6 years. I think when I interviewed, I was fortunate to interview in person, and when I interviewed at Rutgers, I said, this is totally the place for me. Everyone's so cool and down to earth, and they're just from all backgrounds, and it was such a melting pot. I was like, these are my people. Find your people.
So going along with that, and I'll open this up to everyone, this is a great question from Jessie, a student at Morehouse School of Medicine. How do you go about reaching out to mentors in the plastic surgery field if there isn't a plastic surgery program at your home institution? I'm wondering, Hari, if you could speak for your own experience if you did that, and then Paris and Michael, some maybe experiences that you guys have and your work you're doing on the national level.
Yeah, so like I mentioned, I got interested in plastics because of the micro meeting. And so I actually just emailed everyone I had met at the micro meeting and I was like, do you have any advice? I want to apply. I didn't even know I had to do away rotations at that point. And I also reached out to every single person like the last 10 years I graduated from my medical school who had matched into an integrated program. And I just talked to so many people, and I'm a little OCD and I kept all these little notes everywhere. And I was like, okay, I guess this is what I'm supposed to do. So I think now hopefully it's a little easier if we could connect mentors and mentees, but then also have a subgroup of mentors that are interested in specifically mentoring underrepresented minorities, which I think we've set up on the website, which is great.
Yeah, I think definitely if there's specific programs that you're interested in, that was one of the goals of setting up the whole liaison system. I think, program directors and faculty are really open to talking to applicants this year. It's really kind of a whole different dynamic than it has been in the past, since a lot of those in-person opportunities don't exist. So if there are places that you're interested or programs that you're interested, I certainly, check the liaison list on the websites. All of those people have offered to talk to them. And a lot of it's the leadership of that program.
I think that program I think that makes so much sense to have that ability to have someone just be able to reach out without, you always worry about, I'm connecting with the program director. I have to make sure everything's perfect. My email has to be perfect. My conversation has to be perfect. And so it makes it more of an informal meeting with programs. And so the other thing, so just in this last year, I posted something on Twitter, and I think I responded, or I said I was available to help. And I had like 4 or 5 students respond to me about that exact issue, that they didn't have a home program. And because of the pandemic, they had no options to do a sub-I. And so I think this has been a particularly hard year for students that don't have home programs. But just with talking with people that I know from other programs, I was able to connect a few actually, and to the point where some of them actually have connected to set up an away rotation after the coronavirus pandemic got a little bit better. But I think that's what I was saying about opportunity is, I was lucky as in where I showed up in residency, I had the opportunity to do research and really set myself up for success. And our field, unfortunately, is reliant on that, right? It's reliant on reputation. It's reliant on its board scores, obviously. There's a lot of barriers. And so I think that just like with the liaison, I think that's a great way to kind of start opening up some doors so people can find opportunities at other places without having, their father's a plastic surgeon or they know somebody who's in a famous lab, but have these opportunities to if this is what they want to do, that they can potentially do it.
I want to comment on the 4th year component of it in a second, but the first year, the person that's just really starting to get an interest in it, if they don't have a home program, as Hari and Michael have said, I've had that inquiry from many students. I would say you have to be a bit creative and even look outside potentially the traditional plastic surgery societies. So although ACAPS has established this liaison. There are, affinity medical societies such as the Latino Surgical Society and the Society of Black Academic Surgeons. I can't tell you how many connections have been made through me because I'm one of few Black academic surgeons within SBAS, or the Society of Black Academic Surgeons. But, if you get in touch with pretty much anybody that's a member of SBAS or LSS, they're going to put you in touch with a Latino plastic surgeon or an African American plastic surgeon. So there are other avenues that you have to your disposal. You just have to seek them out. I also can tell you that the last 3 years prior to this year being canceled, I would attend the SNMA meeting, and I was shocked at how many students would come up and say, Dr. Butler, can I have your card? Can I get your email address? And then I never heard from them. So you have to use your resources. We talk about active mentorship, but there's also active menteeship, and there's really good strategies. Many of us, particularly those that come from underrepresented groups, feel as if it is our responsibility to reach back. So it is not a burden, and I'm sure that Hari and Michael can speak to it too. It is not a burden to receive emails from you all saying, hey, I'm inquiring about this. Can you put me in touch with so-and-so? You may have to give us a couple of days, but we will get back in touch with you. So use the resources and the people that you happen upon. Not to take too much time, but I want to talk about the fourth year component, if you don't mind. So to my mentees that are fourth years that couldn't do sub-Is, or even past years that could do sub-Is as they're trying to navigate, I kind of visualize the training program concept in, like I say, there's 7 big buckets that you have to make sure that you check all of the 7 buckets. But what makes it unique to that individual is how you prioritize those 7 things. So the 7 things for me are kind of the clinical volume and preparedness. So that's one. Research productivity and opportunity. It's the second one. Say the national reputation, or as I like to say, will this program get me to where I want to be in life? Pedigree is kind of strong, but you kind of understand what I'm getting at. Mentorship and sponsorship, that's the fourth one. What the didactics and formal teaching is like, that's the 5th one. What's the culture, climate, and diversity, equity, inclusion would be incorporated into that, as Hari's kind of spoken to. And then last, but definitely not least, is geography and location. So of those 7 things, you need to assess all 7 of those. And then according to you, and they say first be true to thyself, you have to prioritize them. And then when you go to interview, as you're making your assessment, you kind of rank these programs according to that, because at the end of interviews, it's all a big slosh. If you haven't written something down, you can't just go on the warm and fuzzies or the gestalt of a program. So I think those are just some concrete ways to be a little objective about how you discern between programs as you're trying to figure out where you want to spend the next 6+ years of your life.
I'm going to move on to a question from Natalie, who's a 4th year at Vanderbilt, who's applying this cycle. I'm wondering how you might all give advice on how we might balance wanting to be at a place with well-established diversity and inclusion versus wanting to improve a place's diversity and inclusion. Michael, what do you think? And anyone else also, please.
It's a really great question. It's something that is a constant struggle, and it's a constant, we call it the minority tax, where you put in extra work to help and improve diversity and inclusion, and it takes away from your academic time or research papers and other things that you're interested in. I think it depends on what kind of person you are and the amount of support that you need. I think most people appreciate the support of having it already set up in place. It's a similar thing that happens in medical school. It's when I'm giving an example of Stanford, like you go to UCSF, and just comparing the Bay Area, and if you're Latino, if you go to UCSF, they roll deep. There's a lot of Latino students there. If you show up, you feel very comfortable. If you go to Stanford, there's a handful of them. And so it's just your level of comfort of what you think you're going to thrive in. And so I can tell you the reality is in residency, you're really not going to have as much time as you'd like to do outreach work. It's really tough, your rotations and the clinical work and being on call and having time to focus on that, as well as research and other things, and being pulled in different directions and family and other things. It's hard to have that amount of dedicated time that you have in medical school, but in residency you don't. So anyways, I'm not giving you an exact answer, but I think it's a choice that you're going to have to decide. I don't think that you should ever feel like you're the person that's going to provide diversity, and that's why you want to go to a program. And to think that you're going to be put on some platform or something, you're going to fill a box or something. I think you should go the place that feels like it's the best fit for you, and the mentorship's right, and all those points that Dr. Butler put together.
I don't know if Paris or Hari, do you want to add on to that?
I definitely agree with Dr. Galvez. I mean, Dr. Butler had pointed out 7 buckets, and of course, diversity and inclusion is only one of those buckets. So please make sure that you fit all the other criteria, you know, location, culture, mentorship, research, find something that's important to you and go with it. And then, I mean, I definitely believe in being the change, but I don't think that you should feel like it is your burden to check the diversity box for a program. I mean, you should definitely not go to a program that checks no boxes and you're like, well, I think I should bring some diversity there and then we'll see what happens. I mean, if you do want to do that, all the more power to you. And I think it's great that everything is now such a small community virtually, and we will be there for you to be your mentors if you want us to be. But you should really do what is good for you.
Yeah, I echo their thoughts completely. Michael and Hari articulated it well. You don't need to bear the burden of the entire diversity, equity, and inclusion on your own shoulders. I think you can be bold and brazen enough to want to take some of that on. But first and foremost, you need to be supported. You need to be at a place that has the resources to make sure that you are going to be successful. And many of that comes from just good mentorship very broadly, right? You need mentors that, as I say, are made men and women. So folks like Dr. Gosman who have, you know, senior faculty positions. You need to have people that are going through the process. So residents that you're bouncing ideas off. And then you have to have what I call big brothers and big sisters. So people that are just a couple of years ahead of you. That has been instrumental in my walk. I can tell you along each of the steps that I had of people that were just a little ahead of me that I could call on a whim and say, listen, I can't figure out this application cycle or this process, or this interview was a little weird, or what have you. So you just have to make sure that you are, wherever you end up or wherever you decide, and many of you will have the burden of choice, you just go to a place where you know you're going to be supported. And many of those mentors are not going to look like you. I have benefited many, many times from my mentors that don't look anything like Paris Butler, and they are allies of the cause of not just, you know, diversity, equity, inclusion. They're allies of the cause of making Paris Butler successful. So just make sure you have an idea of that as you're kind of navigating it.
Yeah, I would just say that you don't have to be, now that everything's so small, you can join committees. And so you can improve DEI without being at an institution in particular. And the other thing that Dr. Butler told me once was you have to first become a surgeon first, right? So until you finish residency or until you're like board certified, that's when you can contribute to change. But if you get held back 1 year, or, you know, if the program is not allowing you to thrive, then it gets really hard to try to think about other things, because the first thing you have to become is the surgeon that you want to be, or the type of doctor that you want to be.
Those are those are great points. I think that you have to finish residency, just like she mentioned, you know, and I think that's a really good point that Dr. Butler's mentioned before, is you have to thrive. You have to find a place that you can thrive, and that you're going to get that type of support, because you'd like to think that people will really, truly, truly care, you know, but you really have to look out for yourself so that you can finish your program. And just to echo what Dr. Butler said also, is I have so many mentors that don't look like me, and I've appreciated their support, you know, male, female, from all walks of life. And so you have to take those on. So
this is a question that actually speaks upon one of the topics that we as panelists were talking about before we went live, from Alexa. Oops, sorry, just moved. As an IMG, this year has been really tough in terms of finding a clinical rotation and getting to create a network within the plastic surgery community. What would you advise an IMG in terms of matching a plastic surgery program? Michael, do you have any thoughts?
yeah, so I tend to send students that are IMG to IMG residents and attendings that I know, just because the experience is very different for them. It's really, really tough. And there was another question about your step score and all that. And Dr. Gosman mentioned about how it's different. But there, and even now with not having a clinical rotations, it's even tougher. I think the most reliable way I have seen IMG succeed in plastic surgery is where they've taken time off to work in a research lab and taken 1 or more years to work with somebody in a research lab. And then in that way, they can get into a lab, work on basic science or clinical research, and then that's usually an avenue to shadow or to see a physician and to get a letter of recommendation from that aspect. So that's the way I've seen the most success from an IMG perspective.
Paris.
Yeah, I once again, this is a really challenging year because of some of the challenges with the administration and the visa situation. I recently went to our designated institution officers, or the DIO, the program director, program directors, and had a very frank conversation about what our capacity was within Penn Medicine to bring on IMGs, and it's going to be very department dependent. There's no blanketed policy that we're going to accept all IMGs with open arms. Some can't afford it. Some we had a situation this past year at the start of this academic year where we had 3 residents that we were anticipating arrival and they never made it, and that puts the programs in a tough spot. So it's not an excuse. I think that this year is a challenging year, but I think the IMG plight is a very, very unique one. I think that they unfortunately are reliant on sponsors, as Michael is speaking to, probably more than the average student or the traditional student that comes from the States. I would say that a year out doing some research is how I have seen some of my IMG colleagues become effective, getting a foot in the door at an institution that they strategically chose because they knew that they were, for lack of a better term, IMG friendly. So I think taking it all in context, I think getting as much information and asking them to be very frank, because you don't want to waste time on a program that's not going to be as receptive to IMGs. I think it's just going to require a bit more homework on the parts of the IMG students.
Along those lines, it's sort of going with this. Do you recommend taking a year to do research after 3rd year of medical school to show interest and increase our chance to match if we decide to do plastics as a 3rd year medical student?
I think that depends on a lot of things. There's a lot of components to your application. And I think hopefully most programs will look at this holistically. So, I mean, yeah, if you have before the step 1 is going past fail, which I'm sure we'll address soon, but if you have like a 300 on your step 1 and you have, phenomenal letters of recommendation, then maybe you don't need to do a research. You're coming from a powerhouse program. But if you're coming from, medical school in DC that doesn't have a home program, you have like 1 publication, you don't know anybody, then yeah, maybe you should do research. I don't think you should do research just for the sake of pumping out papers. It's really to make some connections and form relationships and get good letters, which will really support your application. So it really depends on the applicant, I think.
I totally agree with that. And it depends on the applicant, and that applicant should seek mentorship. I think that is, we can answer specific questions and give specific advice, but you really want to find, and that's all I talk about social media, is you want to find somebody who's going to take you under their wing and help you with your specific situation, where they hopefully have no conflicts of interest and they can help you decide what the next step is for you. Knowing, whether you're an IMG, whether you have a low step 1 score, whether you don't have any research, whether you don't have a home program, there's always going to be some barrier in this multi-aspect part of your application. But you do want to find a real live person that you can talk to on the phone or Zoom or in person, and someone that's going to take you on. And so that's what's exciting about social media and ACAPS taking this on, is I think this will open up doors for students that may not have had the opportunity to afford to consider this. And I think it will be a benefit for our field. So.
You guys have mentioned step 1, and there are a couple of questions that come up about that. So I want to raise that. Many of the panelists mentioned the dearth of underrepresented minorities in plastic surgery. Plastic surgery is one of the most competitive specialties, which includes programs having step 1 cutoff scores that are well above reported average scores of those in underrepresented minority groups. How do you see this changing in the coming years, or do you see this changing? And I'm going to add on to that another question, which is, what do you think the impact of step 1 being pass or fail in 2022 will have on residency applications? That's a whole lot there to mull in together. So Wendy, do you have any thoughts on that?
So, I mean, when I was listening to this question, the first thing that I thought of was nth dimensions. And if people don't know, nth dimensions, which is capital N superscript TH, is an intervention that originated in orthopedic surgery. And for students as a first year entering the intervention, they kind of got support with all these things: mentorship, research, attending meetings, and step 1 support. And so there's a certain degree of cost associated with that, but also they've been in existence for over 10 years now, I believe, and they have phenomenal match rates. So, I mean, obviously I think it's a combination of all of those things, but I think, there's a cumulative career disadvantage, when people come from a little bit more money, they get a little bit better education, maybe they get tutors, maybe they can afford courses. And that all, I think, is all represented in that this mystic number that we're all trying to get. So I don't know necessarily exactly ways to overcome that, but maybe knowing your weaknesses and trying to figure out ways to overcome them that maybe do or don't involve like a bunch of financial investment. Because I think, obviously money helps. Secondarily, I think pass fail is really interesting, because I have heard some programs kind of thinking about like, well, what are we going to use to measure people now? And I wonder if that's going to pressure people to turn more towards research or more towards networking, because those have been measures that have been reported in plastic surgery literature that affect, for example, where you match for fellowship and how successful you are, because it's not really your CV. So that I think will also pressure people who have a little bit more privilege, depending on their pedigree or who they know. So I think as educational leadership, that's something that we really have to be really aware of moving forward, and it's coming quick, so maybe the people who are more senior faculty can chime in as well. I'm curious what they think.
Paris,
Yeah, I think it's interesting, because I think, definitely the pass fail is something that can be advantageous. I think, it just kind of depends what perspective you're looking at it from. I mean, we have pretty good data about those scores for underrepresented minorities. On the other hand, IMGs have traditionally kind of had higher scores, which has gained them entry. So I think, we don't really know what's going to happen, but it's something that we will all need to kind of adapt to. But it'll be very kind of interesting to see how that plays out. Obviously, the hope is that it will make things, more equitable, but it's very unclear what's going to fill that space when that is something that is kind of typically the first cutoff. I would say that even though people do use scores as cutoffs, that most programs are still looking at all the applications. And so even though they may filter for certain characteristics that, you know, I think that there is always kind of a sense that it's not telling the whole story. I think we're getting a little bit close to the end of the hour, a little bit over actually. So maybe we'll take maybe one more question. I don't know, Julie, if you've been monitoring.
Yeah, there's some really good ones. It's hard to pick, so I'll just throw in one last one. I've heard from students that who writes your letters really matters, big names. Is this true? What letters do committees like to see? Thank you.
I'll take that on at first. Yeah, so I think that gets back to my previous comments about having a broadly based mentor kind of armamentarium. I think having some made people in your corner does go a long way as it pertains to the name recognition for some of the programs in which you'll be applying. But I will also say that if you have the opportunity to work very closely with someone who may not have a national reputation, but can speak very succinctly and very clearly and very granularly about the attributes that you can provide, that goes a tremendous way. I guess a little bit of a segue into my concerns about the pass-fail is the fact that you're just going to move the metric, right? We're really good at that in academic medicine. In order to make a distinction between a student, right? So if you look at the AAMC, they have this acronym MAE, so they look at the metrics, then the attributes, then the experiences, and we're trying to kind of flip that on its end for holistic review. So look at experiences, and the path furthest traveled sometimes is brings a lot more value than the distance or the location in which you eventually arrive. The attributes are what you're bringing to the table, which makes you unique. And then the M is the metrics, like the step 1 scores and the number of publications. And I'm just so concerned that if step 1 goes out, then it's going to be step 2. And if step 2 goes out, it's going to be the number of publications. And in all honesty, not everybody can afford 5 years of medical school rather than 4. Not everybody has the resources to do that. So I wrestle with that a bit. I don't think we're going to get completely away from the metrics, but I think it's something that we will be mindful of. So I will say, when it comes to the letters have always been of value. I think they will continue to become of increased value. And you want to pick letter writers that are going to write a lot about what you bring to the table as an individual and what makes you unique. Because that's what someone like myself on an admission committee or selection committee is really going to be paying a lot of attention to.
So I want to mention something, which is I've been doing a research project with some linguistics professors, trying to look at how male or female applicants or different demographics or applicants are evaluated. And I don't have the results from that study yet, but I will say that there is a lot of literature about how male and female residents are evaluated differently, the different language that's used, and also race. And so, sometimes some letter writers will maybe say, hey, give me your CV, your personal statement, and are there some things that you definitely want me to mention? And I think that's a place where maybe you can have a little bit of control, even though you're coming from like a below position, trying to manage up, to maybe for you to be mindful of those things. And if they ask for that type of input, then try to use language that is going to benefit you. And something else that I was going to say. Oh, and the other thing that I think after reading so many letters of rec is that if you can remind that letter writer of anecdotes and stories from your personal life that have shown grit, because I think grit is a really important prognosticator of success in residency, or of during your time together, either as researchers or as clinicians, because I think those vignettes really stand out when you're reading letters upon letters about just people's CVs, and you read the CV, then you read the letter that's just the narrative version of the CV. I think vignettes about personal things, especially your background, where you came up, where you grew up, hardships that you've come through, those really stand out.
I just wanted to respond to one question. Can medical students get involved at the diversity task force? The answer is yes. We want medical students to be involved because you will be mentoring the next generation as well, or just someone a year or two younger than you. I would say for right now, since we're still really pulling everything together, is just please email your contact information and your interest to the ACAPS administration, and they will forward it to us. I'm very excited that you all want to do some work with us too.
So in the interest of time, and I know it's late on the East Coast, any final kind of words of advice from our panelists? We can go around and before we conclude. Paris, you want to kick us off?
Yeah, so I think, you know, Wendy's final remarks were outstanding regarding the letters. I didn't want to leave this call without making sure that you all had an understanding of how important your letters will eventually be as you're going through the process. The idea of grit, the idea of dependability, follow through, like those are things that really resonate with program directors, they resonate with faculty because, you know, being on the other end of this, we understand the longevity of the process. Don't sell yourself short. If you're given the opportunity to be able to contribute or help guide your letter writers in any way, take full advantage. Don't just say, oh no, whatever you write is going to be okay, because whatever they write is probably not going to be okay. So I think you have to have a little level of assertiveness when it comes to those. But your letters and the connections that you make as you're getting close to the process of, you know, of ranking and being ranked, you know, are incredibly important and valuable. I think that the other last parting words I will say is to once again use your resources. If someone offers you their email address, if someone offers to be a sounding board or a mentor from afar, then check in with them from time to time. Be active in your mentorship because that goes a long way. Menteeship, that goes a long way.
Thanks, Paris. Ari?
You really can't also stress enough how much your letters count. I don't think there's any study that shows that a higher step 1 score makes you a better surgeon or a better doctor. So your letters are so important. After reading like a bazillion of them, it doesn't even really matter who writes them. You can have, you know, one of the insert big name here write this very generic letter. It's just reiterating your CV and it means nothing. Or you can have like a lesser known plastic surgeon who is like, this is the best person I have ever worked with in my entire life. And if you do not match, like rank this person to match, you are stupid. That's the kind of letter that I want to read. I'm like, okay, like, you know what? Even if you got like a 225, something must have happened. You maybe had a flu when you were taking step 1, but this person is saying that you are amazing. We have to interview you. We have to meet you. There's something about you that is good. So don't give up. There's always a way. If you want to be a plastic surgeon, there's always a way, no matter what your scores are, what your application looks like.
That is awesome advice. So just things that we've mentioned already. I think you have to be assertive. I think you have to look for, if you find an opportunity, like if you meet Dr. Butler, you better follow up and send him an email. You know, he's going to respond. He's going to give you amazing advice. And there's many mentors in plastic surgery that want to guide you. So mentorship, and then really just explore the specialty. There's a lot of surgical subspecialties. So you really want to make sure that it's the right fit for you. Make sure to explore all the aspects of plastic surgery, whether it's hand, breast, cosmetic, head and neck, etc. So, but I think mentorship is the main thing I would say for the key thing that you want to find. It'll bring everything else.
I know we've gone over, there's just one last question. I'm hoping, Amanda, you can address this. How do we reach out? How can medical students reach out and get like these cold calls basically and get hooked
Yeah,
up?
absolutely. So, I mean, we really kind of put out a call to both faculty and residents who are willing to be contacted by applicants. So that list is live and it's on the ACAPS website. So if you didn't see that initial view of the website, you can go to the homepage and click on the link. It's actually right by the diversity webinar or under the resources. A lot of our emails are on there, so you are welcome to contact any one of us. We're happy to put them in the chat as well, but we definitely wanted to incorporate all of your input and feedback and you know, I think this year more than any other year, people are really sympathetic to the difficulties that are faced, not just by, you know, underrepresented minorities, but definitely people who don't have a home program. And, you know, it's just kind of changing the landscape. And I think this disruption, although it's very unsettling for the applicants, is also a great opportunity for change, because I think really the way things were happening in the past was very inequitable. And that, you know, a lot of the way rotations were deals that were made between very high power people, and that you never even got sub-Is at top programs unless you knew someone. And then, you know, those top programs never interviewed people unless they did a sub-I. So it's kind of a vicious cycle. So I would kind of reframe this year, not so much as being, you know, the you know, anxiety-ridden catastrophe that it could be, as also really an opportunity to level the playing field. Now everyone is kind of at the same place, and we are willing to reach out to you. There are a lot of programs, you know, UCSD started a virtual sub-I, and there's a lot of other programs who have as well. And I would say from, you know, our experience that I actually get more time with the virtual sub-Is, just speaking with them, than I do when you're running around in a busy clinical environment. And that I think, you know, just those like maybe half hour, 1 hour conversations that I have had are things that all of the people on this panel are willing to have with any one of you who are applying. And we just encourage you to reach out, and, you know, we're here to support you. ACAPS is here to support you. And we also want to know, you know, what else we can do to meet your needs and to help to continue to make improvement and take advantage of the momentum that's occurring right now, so that we really can diversify our field. We have an incredible field that we're all passionate about, and we treat such a diverse patient population that, you know, we, more than any other field, I think, should be the most diverse. And I hope that you guys will collaborate with us, and we'll continue to kind of push this ball down the road. Any other last comments? I just thank everyone for their time. I feel bad for the people on the East Coast. So I think we'll conclude here, but please feel free to reach out to any one of us. And, you know, if you want to get in contact with any of us, we're happy to chat with you. And we wish you the best of luck. And please let us know if you want to get more involved in the task force or any of these initiatives. I think there's a lot of you know, research that continues to need to be done, and a needs assessment, especially for people without programs, as I think we're just kind of uncovering a lot of inequities in that whole scenario that we didn't really fully appreciate before this year. So thank you so much to the panelists. You've been absolutely amazing and always inspiring, and I appreciate all of your time. And ACAPS, thank you so much. And Greta, thanks so much for all of your help and support throughout this whole initiative. So follow us on social media, and we look forward to the next opportunity to have this conversation, hopefully on a new level. All right, take care.